So let me start with some facts to set the stage for our conversation today about tobacco use in Indiana. The key takeaways that I want you to come away with is that our rate of tobacco use in Indiana is higher than the national average, and it is much higher for lower income populations. And that's important to remember when we hear more about the report and its findings and the panel conversation. So first, we rank 39th across the country for our adult smoking rate, which is a little over 20%, much higher than the national average of about 15%. We also have much higher rates of pregnant women who smoke. It's 14.3% in Indiana, which is almost more than 80% than 7.8%, which is the national figure. The CDC, the Centers for Disease Control, just released a study a few weeks ago looking at youth use of tobacco, which is also important to remember for this conversation. And more than 7% of middle school students and 20% of high school students report tobacco use. And that's important because once you start, you're more likely to become a lifelong user and an addict. And then finally, according to the CDC, Hoosiers smoke at much higher rates when they come from lower income households. So families with incomes less than $15,000 have a smoking rate of 35.4%, and that decreases significantly as incomes rise. So households with more than $50,000 in annual income have a rate less than 12%. So you see a really stark difference there. So why should we care about this? Isn't this old news? What about the opioid epidemic, heroin? Shouldn't we care about that more? Well, we should care about that, of course, but I also want to make the case for why we should care just as much about tobacco. So the number one reason why we should care about tobacco is it's the leading cause of preventable death and a leading cause of disease in Indiana and the rest of the country and in fact the rest of the world. Here in Indiana, we have more than 11,000 Hoosiers who die every year because of tobacco, another 1,400 who die because of secondhand smoke exposure. So to put that into context, that would be like WFYI reporting every month that there were 2 fatal 747 airplane crashes. It's just a staggering amount of lives lost. And a moment ago, I talked about the opioid epidemic, which we also care about, and I know all of you do too. But right now, we have 10 times the number of people in Indiana who die because of tobacco than we do from drug overdose. And the leading cause of drug overdose is opioid abuse. And then diseases. Smoking causes 3 out of 10 cancer deaths and 3 out of 10 deaths from heart disease. So it is a real problem, and it has a significant human impact in Indiana. The second reason why we should care, if that doesn't move you, is how it impacts your pocketbook and our bottom line as a state. It is very costly to smoke for all of us, including the more than 80% of us who don't smoke. So a couple of data points I'll highlight here is that every household, regardless of whether you smoke, bears a state and federal tax burden of more than $900 every year. We just commissioned a study that was released earlier this year on the Medicaid population only, so just focusing on them. And what we found was, for the most recent fiscal year ending June of 2016, Hoosiers on Medicaid who smoke cost $540 million more in 1 year than Hoosiers on Medicaid who don't smoke. So there's just no question that it is not only devastating in terms of the human impact, but also the economic impact. And of course, this translates to employers. Employees who smoke cost $6,000 more a year than those who don't smoke, which is a drag on the bottom line for employers. And something that we've discovered, which I did not know before our foundation started working in tobacco, is that Indiana actually has a law on the books that protects smokers, so that we can't actually experiment with tools that would encourage them to quit smoking and get some help through their benefits plan at their place of employment. So the takeaways are that we have higher rates of tobacco use in Indiana than the national average. We have more lower income people smoking than higher income people. It has a significant impact on lives lost and then our pocketbooks and our economy. So what is the Richard M. Fairbanks Foundation doing to combat what I've heard referred to as the forgotten tobacco epidemic? A brief overview of our foundation. We were established by Richard M. Fairbanks, who was a longtime resident in Indianapolis. He owned a private communications company that operated, among other radio stations, WNAP, Naptown, and WIBC. He established his foundation to benefit the people of Indianapolis, and the mission is to advance the vitality of Indianapolis and the well-being of its people. We have 3 focus areas: education, health, and the vitality of Indianapolis, which we mostly define as the life sciences. So within health, and this is a change within the past few years, actually with the help of Dean Paul Halverson from the Fairbanks School of Public Health, was trying to really target what were the root causes of Indiana's embarrassing health statistics. We rank at or near the bottom of almost every indicator of healthy living and health. And tobacco was the #1 root cause as the leading cause of preventable death and disease. And then, of course, the opioid epidemic that we hear so much more about. So within tobacco, what we focus on are 4 strategies. The first is raising awareness of evidence-based policies. The good news is, because people have been smoking for so long, we have a lot of evidence and data about what works. And also we want to expand access to proven prevention and cessation programs. And cessation, of course, means to quit smoking. And then we want to make sure that people are remaining aware about this issue and also the solutions to help them either never start smoking or quit smoking. So we want to support the tobacco control advocacy infrastructure here in Indianapolis and the rest of the state. And then finally, we believe in supporting only those things that are proven or have good potential to be proven strategies. And so we are continuously assessing the data, commissioning research, and evaluating these policies and programs. I'll give you one example of a grant that we've awarded. We awarded a grant to the School of Public Health, and again, Dean Paul Halverson and his team were incredibly helpful. We released a report last fall, and the report did 2 things. It helped us understand the scope of the problem in Marion County and the rest of the state so that we could target our giving resources as effectively as possible. For example, that helped us to identify that there was a high rate of smoking in the Medicaid population. The second is it identified and just laid out what are the evidence-based policies and programs that can be implemented that would actually make a difference here in Indiana. And the report recommended a number of strategies. I'm going to highlight 2 of them, which again I think helps set the context for the conversation that we're going to have this morning. The first is that the most effective thing that we can do to prevent people from smoking and get them to quit is to raise the price, so the tax on cigarettes. And there's ample evidence that shows that every 10% increase in the price results in a 3 to 5% reduction in smoking rates. So it is the most effective tool that we can implement to control tobacco use. The second is to find other ways to restrict access to tobacco, especially for young people. The CDC reports that tobacco use is started and established mostly in adolescence, and that almost 90% of users actually started smoking before the age of 18, and almost 100% by the age of 26. So clearly, once you start, it's hard to quit, and then you become the lifelong addict that ends up as a statistic. And one other note there is that there are a lot of inventive products and ways to make tobacco more appealing to young people, like flavors, et cetera, that make it harder for young people to avoid the temptation, and once they start on a product, because they're more likely to try other tobacco products and become hooked and become an addict. So one of the policies that was outlined in the report was to raise the legal age to access tobacco to 21 from the current age of 18. And the reason for that is to make it harder for youth to purchase tobacco so that they don't become an addict. It also means that when you're 16 years old, you're less likely to have a 22-year-old friend, and so that if the age at 18, you can often find an 18-year-old or a 19-year-old to buy you tobacco, harder to find a 22-year-old. So it also changes the social norms and our culture around access to tobacco. So I invite you to learn more at our website. We publish a weekly blog. We continue to commission research, and we continue to make grants in tobacco. And just again, the highlights are that our tobacco use is higher than the national average. We have more lower income households smoking, and that matters a lot when we get to the retail density discussion. There are proven policies and programs that will make a difference, and we just have to come together and implement those so that we can make a big dent in our smoking rate in Indiana.
At our last health-focused SAVI Talks event in July 2016, we unveiled the SAVI research report called Worlds Apart. That previous report, which was led by, the research was led by Tess Weathers, who's in our audience today, I see, revealed that there are major gaps in life expectancy in Indianapolis, and depending on where in the city one lives. Someone living in a northeast suburb of Indianapolis can expect to live 14 years longer than someone living directly south of Monument Circle. We know that such gaps in life expectancy do not occur randomly. Genetics only play a partial role. Lifestyle is thought to play a large role, but social and environmental factors are important contributors to health as well. And these factors have an even greater potential impact than healthcare, and so they're worth examining. Variations in life expectancy, such as those that exist in Indianapolis, can be caused by differing socioeconomic, cultural, and environmental conditions. Some populations have greater access to health promoting and health protecting resources, for example, to adequate food, housing, and education. Conversely, others have greater access to or exposure to potential threats, for example, poor working conditions or poor water quality. One of our notable threats, health threats in Indiana, is tobacco. And as Claire mentioned, the September 2016 report on the tobacco epidemic in Marion County and Indiana, which was developed by the Richard M. Fairbanks School of Public Health for Fairbanks Foundation, provides strong evidence for why we should care about tobacco in our community and also what we can do about it. It was this report that spurred the SAVI team to look more closely at the tobacco environment in our city. As Claire mentioned, tobacco is a greater problem in Indiana and Marion County than in the country as a whole. As Claire mentioned, our smoking rate is over 20%, which puts Indiana in 39th place. And over 11,000 Hoosiers lose their lives each year because they smoke. And while smoking rates have fallen dramatically over the past 50 years, among vulnerable populations, such as those in poverty or with less education, the rate has fallen much less. And this gives us reason to examine potential social determinants of smoking. Although the harmful effects of tobacco are now widely known, the tobacco industry has retained its presence in the U.S. There are over 375,000 tobacco retailers in the U.S., and almost $8.5 billion is spent annually on health promotion. Much of this promotion occurs at tobacco retail sites because point of sale is one of the few remaining places that tobacco retailers have to target potential users. So examples include display of information on sales prices or prominent in-store display of product placement. So research studies have shown that retail access to tobacco is associated with smoking initiation and with failed attempts to quit smoking. As such, tobacco retail density has become a measure of environmental health risk. A higher density of retail tobacco outlets can provide more opportunities to purchase tobacco and also increase exposure to point-of-sales marketing. Research in other cities has shown that the local density of tobacco retail outlets provides populations in poverty with greater access to tobacco products, and also the tobacco industry with greater access to those vulnerable population in terms of the point-of-sale marketing. So we were curious, what does the tobacco retail environment look like in the Indianapolis metropolitan area? We were wondering, are there notable differences in the socioeconomic characteristics of groups with high versus low access to tobacco retail outlets? So we collected locations of all certified tobacco retailers. We also have counts of births to mothers who smoke. We have socioeconomic and demographic population estimates from SAVI, and finally estimated smoking rates from CDC. So we learned that there are approximately 8,600 licensed tobacco retailers in Indiana and approximately 2,000 in Indianapolis. And we were interested in looking at three different factors about tobacco density and access. One, we were interested in where retailers were clustered. Also, we were interested in how easy it was to get to a retailer. And then finally, how near is one to a retailer at any given place. So the first two factors, retailer density and network density, account for individuals' ability to walk or drive to a nearby retailer, whereas the final measure, the accessibility, is where an individual may be exposed more often to the presence of tobacco retailers. So we combined these three different factors to develop a retail access score for each census tract in the Indy Metro area. We then clustered the tracts based on those access scores to find low, medium, and high access groups. So in this map of our results, the high access areas are depicted in the dark orange, medium access are in the medium orange, and then the low access in the beige. So this shows, we see that in the urban core, we've got higher access to tobacco than we do in the more suburban areas. So based on this this grouping, that again is based off of the location of tobacco retail outlets, our next task was to compare the socio-demographic characteristics and health behaviors of these three different access groups. So we wanted to see how these three different access groups compared in terms of the population makeup and also health behaviors. So we found that maternal smoking is nearly twice as high in twice as high in high access areas than in low access areas. So in the high access areas, maternal smoking is 22.5%. Versus little over 12% in the low access areas. And it's notable that, it is twice, the rate of maternal smoking is in high access areas is 1.5 times higher than the maternal smoking rate in Indiana. So we're definitely have identified, or we're seeing a correspondence between high access areas and areas of high smoking. We also found that poverty is more than 3 times greater in high tobacco access areas. The poverty rates in high access areas was 34%, whereas it was just a little over 10% in the low access areas. In terms of education, high access areas also have 3 times more adults without high school diplomas than in the low access areas. So it was 23% compared to a little over 8%. Finally, the percentage of households without access to a vehicle is more than 4 times higher in the high access group. So we see that it was 4% in the low access and 18% in the high access. So residents in high access areas who may have more limited mobility may more often find themselves in close proximity to higher concentrations of tobacco retailers. And finally, the high tobacco access areas also had the highest percentage of people with color. The medium access areas also had a higher percentage compared to the low access group, almost twice as much. So mapping the tobacco access in the Indianapolis metropolitan area reveals that vulnerable populations have more retail access to tobacco than other segments of the population. And this provides information about where and about toward whom interventions and resources can be targeted. And as alluded to by Claire, there's been a wealth of research on what does and does not work in terms of tobacco control. The Institute of Medicine developed a national blueprint in 2007 that had over 40 recommendations relevant to federal, state, and local action. Here I've pulled out those just related to the state and local level. There's about 10 of the 40. And so some of the items that Claire mentioned, and that will be discussed later, are funding state tobacco control activities at the level recommended by CDC, increasing excise tax rates. There are recommendations for point of sale action, such as regulating retail point of sale of tobacco products, restricting the number of tobacco outlets, and limiting visual display of tobacco advertising. A recommendation that for the state level, also to healthcare partners, is increasing demand for effective cessation programs. And at the local and state level, recommendations are banning smoking in all non-residential indoor locations, supporting the efforts of community coalitions to promote prevention and cessation programming, considering the populations that are disproportionately affected by tobacco when designing and implementing prevention programs, and ensuring health communications are culturally appropriate, and that special outreach efforts target all high risk populations. In other states, they are, some states like Rhode Island are restricting, our province anyway, are restricting price discounting. There's restrictions of pharmacy sales, restrictions of land use and point of sale advertising. There is a nonprofit group called Change Lab Solutions that is working with community organizations across the nation to help educate them on potential interventions and action that works.
The leading cause of death in this country is related to tobacco. It is the leading cause of preventable death. And tobacco impacts nearly every disease, and frankly, tobacco makes just about every disease worse.
I thought this data was so powerful. And when I looked at the data, I think it really emphasized the impact of health literacy on communities and what their resources are. I'm an environmentalist, so you look to see where toxic waste plants are maybe located. You don't see that in suburbia, high-income places. Why is that? Because those communities have a significant amount of resources. They talk to their policymakers to say, hey, that's not going to be placed in my community. But when you go to areas that have very high poverty rates, economically, places that don't even have grocery stores in these areas, their health literacy is such that they may have difficulty accessing health care until the Affordable Care Act came along. Folks didn't have access to health care. So what does that mean? I don't have access to health education and promotion to tell me about things that are harmful and not. And so this are vulnerable populations who are being impacted because of the challenges they may have related to the low economics of anxiety type of things. They self-medicate themselves, so they're really vulnerable to what I consider that when you have this high concentration of tobacco outlets, it may be a predatory type of impact that we're seeing with these populations.
Yeah, I think it was mentioned in the SAVI report, and I also did a little other research. The tobacco industry specifically targets these neighborhoods. So it goes beyond the fact that there's a density of retail outlets, but they're also targeting these neighborhoods with advertising and marketing, and so.
The really scary part about this is when you look at the rates of smoking, especially in Marion County, the highest rates of smoking are in African American men. So when you have these vulnerable teenagers, our study in Marion County showed that of our 18 to 25-year-olds, 48% stated that in the past 30 days, more than 15 of those days, they felt they were in poor mental health. They couldn't even carry out normal activities. So what does that mean? That means they want to self-medicate themselves. So it's just like check cashing places. I need some money, but wow, the interest of those loans are like at 400, 500% higher than what you would see in suburbia. It's not fair to those young, vulnerable children to have frequent access and health promotion related to tobacco. Any place you go into, right front and center, they're exposed to that on a constant basis.
It created for us clear, in my view, evidence of the predatory practices of tobacco companies, and it further brought into pretty clear relief the task ahead. You know, people kind of wring their hands and they say, oh, we smoke. Well, yeah, we smoke. But the reality is, we know what to do about it. You know, this research is wonderful. But at the end of the day, we know how to actually bring this number down. And there are states that frankly have smoking rates that are half of ours. How did they do that? They basically said enough is enough. Let's implement practical policies that would restrict smoking and frankly do everybody a favor. And to me, it redoubled my interest and my focus on making sure that we try to do a better job, perhaps, of communicating the just absolutely urgent need to take action and to move forward in reducing this health threat to even our most vulnerable populations. So if we start, we'd look at almost 12,000 deaths. Just imagine, and Claire did a great job in the imagery, 2 747s a month that crash and everyone dies. And every seat's full, by the way, on that plane. Now imagine 12,000 caskets. It's just unbelievable. That happens every year, or 11,000, whatever. It's between 11 and 12,000. It's a lot of people. That's a lot of funerals. That's a lot of people that lose loved ones, and it's the leading cause of death. So you'd say, well, if we went to the death certificate, would we actually see tobacco as the cause? No. You'd see a whole lot of other diseases, cardiovascular diseases and diabetes and chronic obstructive pulmonary disease and a number of things. But the reality is this really is the protagonist to everything else. The other issue is it's about money. And sometimes, particularly when we talk with our policymakers, they say, well, you know, these are lifestyle choices. People are doing what they're going to do. Well, let's talk about $6 billion. That's a lot of money. I don't know about you, but to me, that's a lot of money. About half that's related to the healthcare costs. Another half of that's probably is related primarily to productivity loss. All of those things that actually take away jobs in our state and rob the average family over $980 in additional tax to each household in Indiana due to the costs related to tobacco use. So we know it costs a lot of money, and here's the thing I think that gets a lot of people, it certainly got me. For every pack of cigarettes sold, and this was in Claire's comments as well, $15.90 goes to health expenditures and lost productivity. So you sell a pack of cigarettes for around $6, and the state incurs a cost of almost $15.90. It's just, you're not going to make that up in volume. So the reality is we really have to think more broadly about if we really cared about the economy, if we cared about increasing the wealth of our citizens, if we cared really about the serious recruitment related to bringing in new companies, there is a strong linkage between tobacco rates and our healthcare expenditures. And so, again, all of these things suggest to me that at the end of the day, tobacco is both a really bad thing for our economy as well as for our health. And the other thing is, frankly, let's talk about well-being. You know, it's one thing to talk about people that are dying, but you know what's perhaps, and some would say worse than dying, are people who live a terrible life because they can't do what they want to do. They can't walk, they can't see, they can't get to the point where they can actually do the daily tasks of living. And so that quality of life that's taken away from people is in large part related to an addiction, frankly, which we know how to deal with and which we refuse to deal with.
One of the things that's probably the number one killer of cancer in Marion County is lung cancer. And as a result of our smoking rates, our incidence of lung cancer is 20% higher than the national average. And if we break our smoking rates down by demographics, we find that the African American male has about a 17% higher incidence rate, meaning 17% higher number of lung cancer rates, and it has a 20% higher mortality than their white counterparts. And so the frightening thing about lung cancer for us is that it's one of those cancers that even though we have the treatment, life expectancy is not that great in terms of cure rate. By the time you make the diagnosis of lung cancer, I'd say over 80% of them have metastasized. So that's the frightening news with this particular cancer. But I also want to highlight that Marion County is also recognized in the state of Indiana, probably number one for air pollution. So when you have industry that is putting out a lot of smoke and air pollutants in the air, that combination now almost triples the smoking rates and the secondhand smoke that we see in these vulnerable areas because you have a higher concentration of that industry in the inner city areas contributing to air pollution. Back in 2011, our overall smoking rate was 30%. Fast forward to 2015, we are at 21.8%, so we've seen a significant difference. We think we've had two smoking air ordinances, smoking bans, however you want to call it, that were passed. The first one not as comprehensive as our second one, which occurred in 2012, and we think it's made a significant difference. And I think there's been a recent study to show that our heart attacks dramatically were reduced, we feel, related to that smoking ban. But let me tell you, it took over 10 years to get the first smoking ban.
You know, Carmel, the other thing that's important to say is that although we have a clean indoor air law in Indiana, if you look at the industry actually that books conventions and so forth, we don't really get full credit for our law because it's known as one of the weakest laws in the United States. So we get to check the box that says we have it, but just barely. So one of the few things I think that can be done even with the preemption language is what Dr. Kane just mentioned, is the strengthening of indoor air laws at a county and city level. So I think that's a great testament to what could be done yet.
Marion County has one of the stronger ones in the state, as I recall. You mentioned preemption laws, so I want to just bring up something I learned from research. With the SAVI research, you know, one of the things that Karen pointed out is the Institute of Medicine recommends possible regulation at point of sale, maybe to regulate advertising or discounting to make this tobacco retail less appealing or less targeting to vulnerable populations. In Indiana, that's impossible because of a law that was passed in 1997 saying that localities can't cannot pass their own regulations.
$280 million a year is what it's estimated that is spent by the tobacco companies in Indiana for marketing, plus hundreds of thousands of dollars that go to lobbying and political contributions. And I think that's the linkage between why we have the preemption laws, because it could hurt the tobacco marketing if, in fact, local communities could get together, like Dr. Kane just said, and make an intelligent decision. So it's a business interest issue, I think.
Interesting. You get asked, we all get asked to do things that maybe you didn't raise your hands for. And I was asked to become the chair of the Indiana Hospital Association. And it's an honor, privilege, but I also believe that when you're placed in a position of leadership, you have influence and you need to do something more than just conduct meetings. So it just so happened the day before I was placed into that position, the recent health status reports came out, or one of them, and it showed that Indiana was 41st. And you think about what we have here, especially from healthcare and big pharma and diagnostics and medical devices. I mean, it's a pretty amazing place, and large insurers.
It's our economy.
It is. And the B41st just didn't make any sense. So I took a flyer, and when I accepted the position, I stood in front of my peers and said, I would like, this information came out, I would like for us to take responsibility. I know we can't fix it on our own, but we can be conveners. We're the largest employer in most counties. We have influence throughout. And I would just I asked that my peers would let me know if they're willing to take the responsibility to convene. And instantaneously, I heard from my peers, 100 people around the state that said, yeah, you're right, we should quit looking at our shoes and try to do something about this. So at that point, I thought, oh my, now what have I done? So, wasn't looking for another job, but you understand that your gut tells you that other people feel like you do, that it's embarrassing. It truly is embarrassing. And so I reached out to the State Medical Society. I reached out to Anthem. I reached Paul Halverson and I talked. Claire Fittian-Green and I talked. I talked to the head of the Indiana Chamber, Indianapolis Chamber, over and over, and everybody said, yes, we're willing to do this. So we decided to convene. We didn't form another 501c3. We don't need one. We don't have any type of dues. There's no association. It's just, can we bring our collective wisdom together, and can we say, how do we improve the health of our citizens? And that's a daunting task. And then you start looking at data, like the data we're looking at today, and other data that's available. There's plenty of it out there. The problem is, any way you slice it and dice it, the best we are in anything in the country is 35th. That's our best. We go from 35th to 49th, and it's appalling. So we had a long conversation. Do you focus on infant mortality? Do you focus on obesity? Do you focus on childhood obesity? What do you do? And we decided that smoking, for a lot of reasons, was the right place to go. And part of the reason was something that Paul referred to, is the fact that there's so much evidence out there that says, how do you address it? That we don't have to go reinvent something. That we can just take this evidence, we can pull our coalition together, and we basically said that we're going to start with tobacco, not end with tobacco, start with tobacco, gain traction, go forward, and address a number of other crises that we have. And within tobacco, we said that the things we're going to do is that we were going to, one, raise the price, and Claire talked about it in her presentation, and we asked for $1.50 per pack increase in price, because not that we were looking for revenue, the state's going to get the revenue. We were doing it just to drive down incidences, and so therefore you need to supplement that with our second one, which is additional dollars for cessation. Those dollars have been cut dramatically ever since the tobacco settlement. Third was interesting part, and it gets back into what you can do in a municipality. But that's the other thing. We also reached out to Matt Greller, who runs Accelerate Indiana's municipalities. So that's kind of the convener of all the towns and cities. And they immediately jumped in and said, absolutely, we need to do this. And in there we said, hey, there's amazing research about the reduction in incidence when you do increase the age to 21. And this Tobacco 21 came. And So that was our third piece, and our fourth was again something that Claire talked about. I again ignorantly did not know that there was a regulation that has preferential treatment for smokers in the workplace. Had no idea, but I can tell you as a large employer, it ticks me off that I can't do something about that. And so when you put all those together, that's what we said we're going to go try to attack.
But in this case, the tax is the intervention. The tax is the treatment. It really isn't about what you use the money for. It's really about raising the price of the product. If we can raise the price, we can show a linear relationship with the reduction in smoking. And so in this case, I think that they just had such a hard time understanding it wasn't about the amount of money that they could use for whatever. It was really about raising the tax, which is the intervention itself. And I think that became the really difficult thing. By the way, I have a good idea. You know, Indiana is ranked 49th out of 50 in terms of our per capita funding for public health. If you want a good reason to raise the tax, I mean, we could certainly use money for public health, which focuses on protection and improvement of the people in the state. But I think they didn't get the connection that the tax really was the intervention. I don't know if
Well, I think that's true. I also think that we got into a political realm where we're talking about health.
Right.
And they're only talking about money. And so while we were intentionally separating the two because we weren't looking for the money,
right.
It kept being easily misconstrued.
Yeah. If you look at it, and Brian and I have talked about this, if you look at it, the Tobacco 21 initiative, we know that the tax will work immediately and beautifully, and it's got years to show. Likewise, there's increased evidence to show the impact, particularly long-term impact, on changing youth smoking patterns, which if you look at it from a long-term perspective, this is potentially one of the most devastating strategies to the tobacco companies, because we know that 95% of the people start smoking before they're 19. So the reality is, if we can prolong that so that they can't start smoking, and we know also, and I think Claire brought this up, there's a lot of 16-year-old kids that know 18-year-old kids. There are not too many 16-year-old kids that know a lot of 21 or 22-year-old kids. So we reduce dramatically that pipeline, and when we do that, we actually have the greatest likelihood of interrupting the whole supply chain and ultimately reducing the number of lifetime smokers, which I think that's the reason at the end of the day they're going to be most concerned, is because that particular piece of legislation has the greatest long-term impact on their product.
You know, we've got some great partners of our Smoke-Free ND Coalition, and whether it's the American Heart Association, American Cancer Society, or even American Lung Association, and now our neighborhood association folks are getting fired up. I'm delighted to see one of them, Vicki Driver over there, who's in our health department is centered in inner city, Meadows area, high poverty, unemployment is kind of high, and it was refreshing to see a neighborhood association tackle, I think it was Dollar General, trying to add alcohol to their store, and they're saying, no, we're not going to have all these alcoholic retail density units in our community. And I think they actually protested and went on a strike and were very successful in their efforts. And so we need more partners like that, being aggressive. They're now we're going to take back our neighborhood because we're very concerned about our youth. We got to protect our adolescents. Surgeon General said that the electronic cigarettes is one of the most devastating things that can talk to teenagers. So we're trying to go into these areas now to have large apartment buildings that are smokers, trying to talk to them about making their facilities smoke-free. And we're having some successes related to that, to large apartment buildings. HUD made their facilities smoke-free 2 years before the law came out saying that they had to do it in 2016. We're also looking at convenience stores, trying to look at how they display their tobacco, and they're offering huge discounts. So when you come into the store and you got to pay for something, tobacco packages, very colorful, huge discounts for them to initiate them in smoking with our young teenagers. You know, mom sends their teenagers to go get stuff out of convenience stores. So that's who we're seeing a lot in the convenience stores. But we want to raise the age from 18 to 21 of who can smoke. If we can pull that off, that's significant. So we're working also on that effort.
So I have a question about getting the message out to young people. I think Dr. Kane spoke about e-cigarettes, but there's also a thing of like hookahs and sort of these hookah restaurants. So how do we get the message out to young people that those are just as bad as smoking cigarettes, or, and you know, because it's more of a cultural and community thing, especially with hookah restaurants and things like that. So how do we get the message out that those are just as bad and you should probably shouldn't do that either?
So the trick is you honestly have to have resources to do it. You have to have a campaign. You have to have a message that resonates with teenagers. And you have to have them out there doing outreach to other peers about getting that message out. And we have to monitor the places that sell the tobacco to make sure that they're not selling to folks who are underage and they're asking the questions. But it is a really tough issue if you don't have the wraparound items to address social determinants. So, you know, I can talk about, I need you to concentrate on not smoking, but three days out of the week, I'm hungry, I'm starved, I got no food, I'm under stress. My mother says we may be kicked out because we're not sure we're going to have the rent. And so we've got to, you know, what kind of activity, physical activity that I can do to make me feel good. I'm not depressed. It can calm my anxiety. What kind of programs do we have for young youth to really get them involved with some things that will make them physically improve their well-being? And I think until we start addressing those kind of issues, it's going to be very tough to just try to fix that one piece void of all those other challenges that are facing them.
The issue related to community activation, I appreciated Miranda from the state who was responsible for tobacco cessation and prevention in Indiana, and I appreciate her leadership. But one of the things that the CDC has established is a list of evidence-based interventions that they would recommend that each state fund. How many of you have seen the TV commercials, the tips from former smokers? Have you all seen those? This is one of the most evidence-based strategies in terms of awareness, because we can draw a line when those commercials are on, and they are very graphic and they get you in the heart. But you know what that does? That drives people to call the quit line. So you can draw a line to when those ads are shown and when people call the quit line, and our ability, therefore, to attract people. That's one example of media. But working in neighborhood associations is another approved strategy by the CDC. In fact, they believe that grassroots activation in all of the communities is a crucial part of what needs to be invested in. And so as we think about a relatively poor, in fact, dirt poor tobacco prevention and cessation program in Indiana, there's not as much that could be done, but if we had more money, we could use it wisely to do exactly what you've mentioned, Dr. Kane, which is to get out to the neighborhood communities, to increase the evidence-based marketing efforts towards tobacco awareness. The average person tries to quit smoking 11 times. We can't quit on them. We need to help promote their initiation to start to quit again. So I think this is an excellent example of how and why we need to work towards increasing the funding and changing our policies.